well. This session is also being recorded and will be available for viewing at a later time on our MHTTC website. The PowerPoint slides and any additional resources discussed today will also be available as well. Our MHTTC's mission is to use evidence-based means to disseminate evidence practices across New England, and our area of focus is geared towards recovery through recovery-oriented practices and support services within the context of recovery-oriented systems of care. With that, it's my pleasure to announce our speakers today, Dr. Matcheri Keshavan and Dr. James Feldman.
Thank you, Rachel, and good afternoon, everyone. My name is Matcheri Keshavan. I'm a psychiatrist and also professor at the Harvard Medical School. I have been in the practice of psychiatry for about 30 years now, and for a large part of that, I have worked with people with severe mental illness. And the topic of today in our series of psychopharmacology consultation sessions is on one of the medicines that on which we have a large body of knowledge, that is kind of the go-to medicine for some of the most severely ill people with mental illness, namely clozapine. And with me, I have James Feldman, who is also a psychiatrist and an assistant professor of psychiatry at Harvard Medical School. He has worked with serious mentally ill populations and is an expert in psychopharmacology for again, many, many years. So he is the expert who has seen a lot more patients on a day-by-day basis on clozapine. And I will be turning to him for a number of questions, but I can start with a few basic slides that cover the topic of clozapine so that we get to the real frontline questions that many of you might have. And we already have received some questions from you, but we also have a few talking points that Dr. Feldman has at the end of his talk, from which may trigger some additional questions. So we overall have about an hour, and our presentation of these slides should not be more than about 15 minutes at the most. So with that, let me go to the first slide. Now, clozapine is a unique compound. It's been with us as an antipsychotic, as an atypical antipsychotic for the last over 30 years. It was introduced in the 1960s and 70s in Europe and then came to the US and was shown by a double-blind controlled trial in the United States by John Kane and Herbert Meltzer to be effective in patients who have previously turned out to be treatment resistant to standard antipsychotic drugs. It's a unique compound with multiple effects. So let me see if I can turn the animation slideshow here. So basically, you see the molecular structure there, and it has several properties. And what underlies the therapeutic effects of clozapine are three main effects. One is by the way, all the antipsychotic medicines work by blocking dopamine receptors, as you probably are all aware, especially dopamine D2 receptors. But the unique thing about clozapine is that it has a rather weak effect on D2 receptors, but has many other effects which may contribute to its effects. It may have some effects on D3 receptors and D4 receptors, muscarinic cholinergic receptors, and also serotonergic receptors, which may all have some contribution to the therapeutic benefits of clozapine. Why clozapine is better than other antipsychotics? It may be a combination of all of these different receptor activities, D3, D4, muscarinic, and maybe 5-HT2. So, but on the other hand, clozapine is also not the safest medicine. It has side effects. Think of clozapine as kind of a a multi component tool, like a Swiss Army knife. It's got different receptor effects that underlie different aspects of its therapeutic benefit. But it also has effects on histamine, for example, which causes the weight gain and sleepiness, sedation. And it causes drooling and constipation and blurred vision, which is due to its anticholinergic effects. But also has some pro-cholinergic effect, which is what makes it somewhat complicated. It has an effect on alpha-1 receptors, which is what causes the dizziness and the blood pressure drops, the hypotension. And then there is the 5-HT2 receptors. Clozapine's effects on the 5-HT2 receptors makes it unique because that is what protects the person from having what we call extrapyramidal side effects like Parkinsonism, tardive dyskinesia, dystonia, akathisia. Clozapine is uniquely free from those. That is because of its 5-HT2 effects and also because of its weak D2 effects. So with that as the background, when do we use clozapine? The important thing to know is that clozapine works in those patients who do not respond to standard antipsychotic medicines. If you take all people with schizophrenia, about a third of them don't respond to conventional antipsychotic drugs like risperidone or olanzapine or quetiapine or haloperidol and so forth. It is this 1/3 of the schizophrenia patients in whom clozapine would be indicated. And then even those who do get clozapine, about 1/3 of them do not respond to clozapine either. In fact, one of the questions that came up from this group was, what do you do when clozapine is not working? We'll get to that point. So with that said, the next question is, what are the patients in whom we think of clozapine as the treatment option? Patients with schizophrenia or schizoaffective disorder that are not responding to other antipsychotic drugs are resistant to treatment. Typically, we decide somebody is resistant to treatment if that person has not responded to at least 2 standard antipsychotic medications in adequate doses for at least about 8 weeks each. And such patients would be good candidates for clozapine. Clozapine is also an effective medicine for people with persistent suicidal or self-injurious behavior, and those who have severe extrapyramidal side effects and tardive dyskinesia would be another indication. There are some contraindications like neutropenia, which Dr. Feldman is going to tell you more about, and cardiac disease and seizures. So in any person in whom you start clozapine for the first time, there are a number of baseline assessments that need to be carried out, including a complete blood cell count, height and weight, blood sugar, fasting lipids, vital signs, drug levels for anticonvulsant drugs, ECG, and an Ames rating for involuntary movements, and a pregnancy test in women. I'll stop at this slide because Dr. Feldman may have some comments right from here at this point, and then he'll walk you through how do we start someone on clozapine and how do we monitor progress and measure treatment response. Jim?
Yeah, hi. I guess my thought about this slide is, and there was actually a question about this, at this particular time, it can be difficult to get these tests. On the other hand, if you're starting somebody on clozapine, you have to get blood. So presumably the person is seeing somebody who's both able to take blood and has a blood pressure cuff. So I think those are things that I would say you certainly would want to do. You need to have as a baseline the body mass index. And since you're drawing blood, you can get, I would definitely suggest getting the fasting blood sugar and lipids. There's some question about, in some areas, cardiomyopathy. For some reason in Australia, there's a very high incidence of that. So that's standard in Australia. But for some reason in this country, we don't see as much of it. So it's not a standard thing to get. And then the electrocardiogram, I don't universally get that. I only get that if somebody's on high doses of something that tends to cause high, QTC elevations, such as like thorazine or Seroquel 600. I'll probably then want to do that before I start. I think that's all I have on that.
So what you're saying, Jim, is that this is the ideal. Right. But on the other hand, the minimum is a complete blood count that has to be done.
Right. Where I am, it's, we're right in the Harvard Longwood medical area, but it's hard to get an electrocardiogram. I've got to send somebody across the street. These people have a lot of trouble organizing. So I don't let that deter or prevent me from stopping the medication unless there's a real serious concern.
Yep. So tell me when you want me to move to the next slide.
Let's move to the next slide.
Great. There you are.
So there was established a registry, the REMS registry, as a single registry. There used to be different ones for each manufacturer had to have it, but that all got consolidated in 2015. Very efficient. There's a very quick test that you have to take online to make sure that you're certified to dispense. And the mantra really is no blood, no drug, which is generally absolutely true, but right now you have to, according to that, there's another slide coming up. We'll wait till we get to it.
Yes.
So when people start clozapine, they generally are monitored for the first 6 months weekly, the second 6 months every 2 weeks, and then once a month after a year, which is the longest duration of interval that's below. You can see the parameters for ANC, which apply to almost everybody. There's new information. I think it was last year for benign ethnic neutropenia, and we'll move forward. I think this is important for reference, the numbers below. And I don't think I need to belabor the actual numbers. Let's go to the next slide.
Yeah, this is kind of small print, so let me try to enlarge it. Let's see, can people read this?
Yeah, that's pretty good. This slide is essential. It's the way that I decide what to do. It's very prescribed. It's very complete. It includes the benign ethnic neutropenia population. About 50% of African Americans have benign ethnic neutropenia. Simply means that their ANC white count can be lower, but they have absolutely no symptoms of decreased immunity. And so it's been determined that it's safe to allow their white blood cell counts to drift down further without any ill effect. And the parameters are there, and well spelled out. So this is the best. I keep this on my desk all the time. I would suggest printing it out. It's also very easily available online. If you just put REMS clozapine chart, it'll pop right up.
So Jim, how does one distinguish between an African-American person with benign ethnic neutropenia from another African-American person who has a real serious granulocytosis, or that reduces immunity.
Well, personally, I would never diagnose it myself
Right.
for many reasons. I'm not a hematologist. If you see somebody who's got a low white count, it used to be there were an extraordinary number of African Americans who were like excluded, and that was felt to be biased. And so there was a move to look at this. And if you see somebody who has a low white count, like of ANC of 2000, and you're wondering about what's going on here, you could have them see a hematologist who could make the diagnosis. I think that's important to protect. You certainly want to have that. You want to protect yourself and the patient. Basically, my understanding is they do a serial counts over, I think, 4 months to make sure that there is a persistently low white count. That's mostly what I could find out. I was actually looking it up online, and that's the most that I could get about the diagnosis.
Okay, thank you. So let me go to the next slide. So yeah, in the context of the COVID crisis that we are all currently experiencing, the FDA has given us some guidance in some ways to liberalize the REMS regulations. Since March 22nd, the guidance allows patients to receive clozapine even if there is no laboratory testing, if there are compelling reasons not to complete the testing. For example, because of the social distancing, the patient is unable to come into the building, or the clinic has closed. So it may be reasonable to forego testing, but that could be done only in those patients who have received the drug for at least 1 year, because the risk for severe neutropenia is very low, and in fact not different from those who are on other antipsychotics after the first 1 year. The highest risk is in the first 1 year. So this liberalization is for patients who have been on clozapine for at least one year and longer. But on the other hand, if such patients do develop any sore throat or fever or flu-like symptoms without the ANC monitoring, they should of course be immediately assessed for possible clozapine-associated neutropenia. You want to comment on this, Jim?
I was just to say there are countries that don't have a monitoring system like this at all and just use clozapine without this,
Yes.
which I think underlines the fact that we're being very careful here, particularly after a year.
Yep. And maybe you can, describe the clozapine initiation, Jim.
Yeah. Yep. Usually I start at, so there's some guidelines that suggest using it twice a day, like 12.5 in the morning, and then 25 at night, and then 25 twice a day, and then 50 at night, and 25 in the morning, and then 50 twice a day. But I find it's much easier, and I do not have problems with postural hypotension by just doing it all at night. So if you start at, let's say, 25 at night, I would say this is for, not somebody who's in their, 80s or 70s, but, a young, healthy, or even somebody in their 50s. I'd start at 25 the first night, 50 the next, 75 the next, just increasing 25 a day over 12 days. At the end of 12 days, you're 300. Okay. I tend to stop there, or I also am checking in with the patient every day when I do this kind of titration to find out if they are too tired, they want me to slow up, then I'll just hold it. But I do like to try and get to 300, because somewhere between 300 or 350 and 500 is felt to be ideal. It's one of the few medications in psychiatry that where levels are useful. And it seems like efficacy is somewhere around 300 or 350 to 500, 600. And basically, that's what I do. And that's, we have a clozapine clinic that I ran for a number of decades, and we have that's our standard titration. Basically, is getting up to 312 days.
Great. So, Jim, do you find it useful to look at the relative ratios of clozapine and its metabolite nor-desmethyl-clozapine?
I don't know what to say about that. I haven't noticed it correlating with anything in particular. You can add if some people think norclozapine may cause more side effects. I've also seen some people say that it may actually have more effect. The most of the research has just been done on clozapine levels, period. There's some research done with them added together. I stick with just the clozapine level itself for simplicity.
Yep.
If somebody had a really, really high norclozapine level in excess of clozapine and you were afraid that was causing more side effects, you could add some Luvox. But you probably have to reduce the dose. Luvox can double the dose, but it does tend to drive the decrease the metabolite of the norclozapine and drive it towards clozapine. I have had patients who were like on 800 milligrams of clozapine and had a level of like 100, and they were definitely taking it, used Luvox, and was able to attain therapeutic levels at kind of normal doses.
Yep. Thank you. So moving on to the next slide. There are a few of discussion points, Jim, that you had placed here.
Right.
Do you want to start with them?
I was going to say that in your first slide, you talked about clozapine for schizoaffective disorder and for schizophrenia. I have had a number of patients who just had like refractory. One of the things I do is I treat mentally ill people with problematic sexual behavior, so that could be pedophilic. And this one person I'm thinking of was a teacher who had pedophilia, but really treatment refractory bipolar disorder. And clozapine was one of the only things that could put a lid on that. There was no kind of schizophrenia, schizoaffective type diagnosis I could place on him. So I certainly have seen it, and it's certainly written about.
The reason I didn't put it there is because is clozapine officially approved by the FDA for bipolar disorder?
I do not know. That is a good question.
Yeah, I did not think it was. And but on the other hand, it is general practice for physicians to go outside of the FDA-approved indication when you believe that it works. So it is not uncommon at all. And I have seen patients with bipolar disorder, severe bipolar disorder, benefit a great deal from clozapine as well.
Right. It also reminds me, one of the questions was asked about OCD, and clozapine has been used to treat OCD, and it also has been blamed for causing OCD.
Yes.
It's really kind of a crapshoot as to whether it would help or make worse OCD. That'd be my only comment about that.
Yeah, we'll get to those questions as well. But do you want to mention anything about this slide, about some of the talking points?
Pre-treatment, I think I already went into that. Clozapine monitoring, we did that. What to do if the ANC is drifting down and you're getting worried. I found lithium to be effective for everybody I've tried it on. And I just, when I've taken it away, it starts to drift down and it makes me nervous. I get, it looks nervous making. And when I just leave the lithium at 300 milligrams, I've not yet had anybody continue to drift down. So it's been an effective strategy. I think I've talked about the pros. The idea of putting the clozapine all at night is in part people, if they get too tired and take clozapine in the morning, it's like giving them a sleeping pill, and they're going to complain like, this is making me feel horrible and I don't want to take it. So that's why I favor putting it all at night. It's also easier. Compliance with a pill a day is about 85% in the general population, 65% with twice a day, and 45% with 3 times a day. So trying to keep it, any medication, with once a day at night. People sleep through the side effects is my general tip for any psychiatric medication.
Yeah, I think there was one more slide. Or was this the last one? Yeah, there's one more slide with some other points. Jim, you
So
might.
clozapine levels. So the clozapine level should match the dose. So that's a lucky accident of, I assume, biology, that if you give somebody clozapine 300 milligrams and you check their blood level 4 half-lives later, that's another reason to dose all at night, because when they come in the morning, you've got a trough level. If they took it in the morning, you're going to have a very high level, which won't mean anything, and it will pull you into underdosing clozapine. But I check clozapine levels. Usually I get somebody up to 300 or 350, and then I just let them be, unless they have a lot of side effects, which would be maybe unexpected. So I will get a level then, maybe at 300 or 350, if I'm seeing lots of side effects. If I'm not seeing any side effects and I'm beginning to see some benefits, then I wouldn't necessarily get a level. But if I'm seeing no benefit and no side effects, and either around 350 or maybe even 400, at that point I would get a level just to find out what's going on. Again, if you're giving somebody 400, their level should be 400. That's the average person. I certainly have had people on 400 and their level's 200, and I've had people on 400 and their level's 800. So I would say 80% of people, that rule works. 400 equals 400, but the other 20%, you need to get levels.
Great. Well, why don't we take a break here and see if the audience participants have any questions.
Cash, there is a question in the chat box.
Okay, let me open the chat box. So in order to go to the chat box, I may have to stop sharing, right?
No, it just popped up for me. The little thing on the bottom.
It hasn't popped up on my screen. So do you want to take that question and read that question for the audience?
Yeah, absolutely. The question is, so typically the sexual manifestations are more likely to be bipolar disorder in a general sense. Would that apply to children as well, or is that more complicated due to their age?
Well, I'm not sure what's behind the question. One of my fields of expertise is the MIPSB population, mentally ill with problematic sexual behaviors. My personal belief is that most people with major mental illness who engage in problematic sexual behaviors have some element of bipolar disorder. If you look at the DSM diagnosis, basically there's elated mood or irritable mood plus 3 of the below. Number 7 is increased interest in sex, and number 8 is engaging in sexual activity that causes you problems. So you don't need much else to therefore have the diagnosis based on, committing sexual crimes or unfortunate acts. So I'm not sure then what's behind the question in terms of clozapine.
So Vanessa, the audience should be able to speak and ask questions directly, right? That we should all be able to hear.
Yeah, so anybody can unmute at any point right now during the Q&A and ask their questions out loud or elaborate if you wish.
Hi, this is Nancy. Can everyone hear me?
Yes.
Yes.
First of all, thank you for offering this. So just by way of background, I'm a Navigate family peer, and I'm also the youth and program coordinator for NAMI Minnesota. And my oldest son has been living with schizophrenia for the last 15 years. After his last hospitalization about a year ago, his clozapine was increased to 525 milligrams. I think part of that is due to the fact that he's a fairly heavy smoker. My concern and question is he frequently experiences headaches and stomach aches. He's on lisinopril for high blood pressure, which was added over the last year. He takes medication to prevent constipation. But we bounce back and forth between his psychiatrist, who's highly competent, by the way, and his primary, trying to figure out why he's getting these headaches and stomach aches. And so I guess my question is it due to the high dose? Would it be better to reduce his dose and actually add the Luvox? We're hitting a wall with this, and he's uncomfortable a lot of the time.
Well, this first of all, I would just ask, is clozapine clearly superior to anything else?
Yes. He's treatment resistant, and it does a really great job of controlling his positive symptoms.
Okay. This doesn't apply to your situation, but I did want to say that clozapine, this is something that I wanted to say, clozapine, as Kesh pointed out, is superior in about 30% of people who are treatment resistant. About 30% do better on clozapine. And of that 30%, 10% have what they call the clozapine miracle, which still has residual symptoms, but extremely, people can go back to work and maybe become lawyers, or I've had some people who've gone and become nurse practitioners in psychiatry. But that's 3% of the 100% that might try clozapine. So it's important to make sure that people have tried other things. I've often thought if you did the same experiment, let's say clozapine was something that had been approved 20, 30 years ago and didn't have all these side effects, and then Abilify came along and you tested everybody against Abilify, you find Abilify miracles, which might be 3% of people who tried it. So I always want to make sure that that it's been effective for the person.
Well, I think the question, Jim, here is the headache, right? He is obviously responding well to clozapine. He had not responded to other treatments. So there is this headache. What is, and the abdominal pain? What is causing it, and does it have anything to do with the clozapine? That's the question, right?
Correct.
Yep.
I have not had anybody in the 20 or 30 years who's had a headache that was clearly caused by clozapine, and at the same time, I would not doubt that it's possible. People have unusual, like I might have one person, and any one practitioner see thousands of people. Do you know what his levels of clozapine and norclozapine are?
I don't. His psychiatrist checks them on a fairly regular basis, but I'm not privy to that information. And so that, we have an appointment, a telehealth appointment coming up in the near future. So that would be something for me to chat with her about. The other question, I'm sorry.
If it was elevated, I think the Luvox, being very careful because the levels are going to shoot up.
Sure.
But at very small doses, I've used 12.5, 25 is plenty, and you'll see an effect.
Okay.
And it could be that driving it more towards clozapine away from norclozapine would be helpful. And then maybe also seeing a neurologist, if it weren't now, to see what the nature of the headaches is and whether there's some other explanation, a headache specialist.
Right. Okay, well, thank you. I really appreciate your help.
I was going to say the GI problems are big and can cause, I think a black box warning was added for motility problems and suggesting using laxatives. So that could explain that. But again, I probably would, for an intractable problem like that, I would be involving a GI specialist.
Yeah,
Right.
certainly. If the is he constipated?
Yes, and we've been to the doctor many times. It's been recommended that he go to a GI for further testing, but because of his paranoia, he won't agree to that. So his doctor is just trying to manage his constipation and reminding him to drink lots of water and that sort of thing. But he's a tough
What is he on for? What is he on for that?
For the constipation, he just takes Miralax. He takes Miralax every day when he gets up in the morning.
Fruit.
Well, you could, you could add oral Ducalax or Senna. Those are all
Or
benign.
Docostate, yep.
Yeah.
Sure. Okay, well, thank you so much. I appreciate it.
You had another question, Nancy?
Oh, yeah, I was just curious. So here in Minnesota, as far as I know, they haven't waived the requirement for his monthly blood draws. When I called his pharmacy a couple of weeks ago, they said that as far as they knew, they were still required. And so I'm just wondering what your thoughts are in terms of next steps, because we're starting to approach the surge here in Minnesota, the surge level with COVID, and we're staying at home, and I really don't want to have to take him out for a blood draw if I don't have to. So just kind of wondering if anyone knows how that looks from state to state, if that requirement's been.
I think the thing is, it's the psychiatrist who decides, not the monitor. And so he can prescribe despite that. That's how I read the thing from the FDA. So you'd have to have your prescriber agree.
Got it.
You might want to bring this up with your psychiatrist, and there are these FDA guidelines which we could make available to you that have just come out on March 22nd.
Sure.
So yeah, maybe your psychiatrist will decide based on that.
Sure. Okay. Thank you very much for your time.
Other questions? We could take up some of the questions that came in the mail before this meeting and see how they go in the remainder of our 20 minutes of time. The one question was, what is the logic behind relaxing the REMS requirements? It seems discriminatory. So this question was a little bit puzzling to us, both Dr. Feldman and I. The relaxing of REMS requirements, I couldn't figure out why it would be discriminatory. It only discriminates between those who have been already on been for a year versus those who have just recently been started. There is no other discrimination there.
I thought it might refer to the change in 2015, I think 15, regarding benign ethnic neutropenia.
Huh.
Possibly, but it's almost, that's kind of the opposite of anti-discrimination, because there were a lot of complaints from African Americans that they couldn't use it, and it was just not taking into account their physiology.
Okay. If whoever asked that question, if you're on the line, please clarify. The second question is, when doing a telehealth intake for a new client, first episode client, and has no ability to take blood pressure, heart rate, height and weight, how are prescribers managing this? So the question is, how do we get vitals, blood pressure, heart rate, etc. by telehealth?
I mean, as it's currently configured, clozapine, you have to get a blood draw once a week, then every 2 weeks, and then every month. we have a situation in which we always, at that time, we gather that information. For people who are simply, people who are walking into, I don't know, like Quest or something, getting a blood draw, I would, and you're using telehealth, I don't know, it certainly would be ideal if the person had kind of a home blood pressure monitor and you could just have them do it in front of you. I also don't know that I would be that concerned during these months. If something's been stable, I wouldn't be concerned about somebody's blood pressure changing from week to week, month to month, or even over, a 6-month period on clozapine. I don't think things are going to suddenly go in a bad direction. It's a different story if they're they're dizzy and having symptoms. I don't know what you think, Kesh.
Well, this question comes up if the person is experiencing postural or orthostatic hypotension, which is a problem with clozapine, and if there is dizziness and difficulty in getting up without feeling dizzy and so on, it is likely to be because of this kind of a blood pressure drop that clozapine is known to cause. And that could be judged even without a blood pressure, simply based on the symptoms. But you could also teach the person to take his own pulse. Blood pressure, of course, you need an apparatus to do that. Now, height and weight, if you have a weighing machine at home, that'll be great. If not, an abdominal waist circumference, if you have a measuring tape, measuring waist circumference before and during and after clozapine can give us an idea as to how much weight gain is happening. It's a crude measure.
That's also been found. That's also been found to be a better predictor of metabolic syndrome, I think, is the waist circumference even than weight.
So that's simple. It's, most homes would have a measuring tape, and that's all you need for that. And it is possible to teach people how to take a waist circumference by a virtual, teleconference meeting, whether using FaceTime or Google Chat or something like that.
Right. That should be at the belly button for those who.
Yes, exactly. So what is the consensus about the amount of time that has passed since medical clearance or evaluation? So I guess the question behind this question is, suppose the person had a medical clearance 6 months ago and you want to start a treatment like clozapine now. Is that good enough? Or should it be checked again? Should a medical examination happen closer to the time of starting clozapine or any other treatment intervention?
I mean, again, when you get the blood test, you're going to get those parameters already.
Yes.
The other things you should be marking when you start, not 6 months ago. Like, I'm not sure, like an EKG, I wouldn't really think that that's necessary to start necessarily unless you're really concerned about something, in which case you just have to get one. But one that was normal 6 months ago in the absence of any new events, I wouldn't be worried, and I wouldn't even necessarily insist on having an EKG prior to starting. So are there other parameters in that slide that were?
I can go back to that slide. Let's see here. I don't know how to get back to that slide at this time. Let's see.
I think I have a print of it here.
Yep.
Height, weight, drug levels, vital signs, EKG, AIMS.
Yeah.
A1C. I mean, things like A1C you can get again. Body mass index, waist circumference, fasting blood sugar. All those things are, I just wouldn't, because I think the EKG is.
So that the EKG is the one that kind of raises a question. Maybe Dr. Feldman, you can tell us a little more about how common this cardiac side effect with clozapine is, like myocarditis, and how would one identify those at potential risk for myocarditis so that you can do an EKG in those selected situations. Not in everybody, but in some situations you would need to do an EKG. What are those indicators of risk for myocarditis?
I am not aware that there are risks, that it's pretty random and it quite rare, although I saw one about, I don't know, 25 years ago. We may have had one other in the years since, but it's pretty rare. This was just a young person and it seemed pretty random. Yep. I don't know, are you aware of any specific factors that they found?
What I do know is that, looking at cardiac enzymes could be useful in those who report chest pain or, any symptoms are referring to their heart during a course of clozapine treatment. Looking at their cardiac enzymes like CPK.
Right, I think once somebody's complaining, and I think this person just was kind of generally run down, almost seemed like they had the flu, and then it ended up they had this cardiac myocarditis. But in terms of starting somebody,
what you're saying is an EKG on a routine basis is not required.
Right.
Yeah, that's good to know. So the other question here is a case scenario: a 50-year-old man with treatment-resistant schizophrenia, long treatment with clozapine, now 775 milligrams per day, lost clozapine level 800, now also on adjunctive thorazine 50 milligram and Depakote 375, both per patient request. No response to adjunctive medications, unable to increase thorazine because of prolonged QTC intervals and pancreatitis, continues to be very quiet, suspicious. So here, this is what we are referring to here, the clozapine resistance subgroup. But as I said in my second slide, 1/3 of people on clozapine don't seem to respond to clozapine. What do we do with them?
So my question would be, is clozapine, again, the best that they've done? Some people are on clozapine and it's like, well, I guess that's the best we can do. And they end up on it for years. And then I'll do a review and it turns out there may be clues that they responded to Seroquel. I've got one person who came out on clozapine, but when I looked at the discharge summary, it seemed like he'd actually responded to Seroquel, which he was still on a little bit of. And I got him off the clozapine on Seroquel. He's doing much better. So I would look for things like that. Clozapine, like I said, you could have the Abilify miracle. So I'd want to, and I particularly like to try people on relatively benign medications first that don't have metabolic syndrome. Those would be things like Abilify, Vraylar, Ziprasidone. And there's, the question of how many should you try before going to clozapine. I think people certainly feel at least 2, but I might go further depending on what I was seeing. In terms of clozapine, what can you add to clozapine? If clozapine did seem like it was the best, but not good enough, there's a recent kind of resurgence of the idea of using ECT. We have a case at the Massachusetts Mental Health Center with somebody who wasn't responding to clozapine, but had, because they stopped it. We gave them ECT, they didn't respond, put them on Depakote, they didn't respond, put them on Dilantin, they didn't respond, then added Tegretol, did ECT. The patient did amazingly well for 4 years and ran the gift shop until Christmas Eve when she stopped it for reasons that are unclear, and at that point was lost to my follow-up. But there's a lot of evidence that maybe up to, I was just reviewing this morning, about 80% of people who get on clozapine plus ECT have a substantial improvement, which goes away if you stop the ECT. So the follow-up maintenance ECT would be every 2 weeks or every month. But surprisingly good results. It's not used that often, but it's something to consider. Also, Abilify added to clozapine has been shown to mitigate weight gain and metabolic syndrome. Because of that research, though, they've also looked at Abilify as something that can be added, and it does seem to have some clinical benefits, not huge, but some. There's also a literature on adding Lamictal. So if you go above about 500, certainly above 600, there's a risk of seizures, which would be the harbinger, would be what's called a myoclonic jerk. But in any case, if you go above 500, certainly 600, you need to add an anticonvulsant, and the anticonvulsant I would suggest is Lamictal. When Don Goff did some of that work here and did demonstrate some benefit from adding Lamictal in some patients, and I've seen a few patients who got substantial benefit from it.
Yeah, I think those are very good points, Jim. Lamictal is interesting because there is this theory that there are two types of psychotic disorders: those that are related to dopamine, which respond to the standard antipsychotic medications, and clozapine works in them as well. But there is another group that may have something to do with glutamate, an excessive runaway activity of glutamate in the brain. And Lamictal, being a drug that reduces the release of glutamate, might reduce psychosis in some such people. So it's an interesting angle. The other thing that I have read is that combining clozapine with a strong D2 blocker, because clozapine is weak when it comes to D2 receptor effects. So using a strong D2 blocker like risperidone, rather than using yet another clozapine-like compound like quetiapine, might be a better option. And in my own experience, I have often combined a strong D2 blocker like trilofon, perfenazine, along with clozapine. Trilofon in the doses of between 12 to 24 milligrams. That has been effective.
Herb Meltzer also did a study with olanzapine, not clozapine, using it at above the FDA limits to maybe 50 milligrams. And he demonstrated in 2 different studies that it seemed to be as effective for treatment refractory people with schizophrenia as clozapine. I've used it a few times, and about 50% of the time, it seemed effective.
Great. Yeah. So last question I have here is about someone who has OCD. This person is on Zoloft 225 milligrams for severe OCD with no effect, residual chronic delusions, nocturnal enuresis, treated also with Detrol. What are the suggestions for adjunctive antipsychotic meds? What about pimavanserin, lumateperone? What about decreasing clozapine dose and adding Luvox? So how does one treat someone with schizophrenia, with OCD on clozapine?
Is that the assumption? I guess that's the assumption. Clozapine can both, I try to figure out whether the person had OCD before being on clozapine or not, because clozapine can both cause OCD and it can also sometimes be helpful in treating it. And if it seemed like the clozapine had caused it, you'd have to do some kind of risk-benefit analysis about whether to continue it or not. Now, in terms of just treating OCD, treatment refractory OCD, adjunctive to Luvox, Topamax would be something that I use. There's evidence that Topamax can help treat treatment refractory OCD. There's a bunch of lines of evidence. There's one comes from, it's both treated, it's used in alcohol, and that's where people like wake up in the morning and they're like, I gotta have a drink, I gotta have a drink. And they can wake up in the morning when I've talked to people and they say, well, I woke up after starting Topamax and I didn't have this voice in my head saying, yeah, I gotta have a drink, I gotta have a drink. I could think about other things, which is kind of sounds like OCD. There's also in character disorders, it seems to have some benefits. And when they looked at what it is, it's kind of an internal negative dialogue, like you're a horrible person, that it decreases that experience. And so in OCD, obviously a similar situation. In the alcohol, they've done some studies and they found that there's a genetic subtype. They don't know what the gene codes for, but it's mostly, they found that in alcohol, it's not effective at all, but with this gene, it is effective. And that gene is predominant in a high number of Eastern Europeans. And I've seen it be extremely effective sometimes for alcohol and OCD. So Topamax could be something to add.
What do you think about anafranil, that is clomipramine?
I think, anafranil, there's no evidence that anafranil is more effective than high doses of SSRIs. It certainly has a lot more side effects. In a treatment refractory case, I could see adding some of it, perhaps. My experience is a very side effect, high, heavy medication, but when somebody's treatment refractory, that's when you start to back into things with more side effects.
Yep.
I don't know what your experience.
We are close to the end of our session. We have about a couple more minutes. Are there any other questions from the participants? So if there are no other questions, I would like to thank all of you for participation, and thank you, Dr. Feldman, for your expertise, and look forward to having more of these kinds of interactive sessions. And thank you to MHTTC for making this possible.
Thank you, everybody.
Bye-bye.